Hello, my name is Sven. I am a neuroradiologist from Belgium, and welcome to this video on 75 neuroradiological signs and old minis every radiologist should know. So in this presentation, I'm going to talk about imaging signs. We all know them, we all use them, but what are they exactly? So by way of introduction, I'm going to situate imaging signs into the cognitive framework used by radiologists to look at images. And contrary to popular belief, radiologists have the same cognitive function and skills like everyone. We have a fast cognitive system, or so-called fast thinking, which is continuously running in the background. When we look at an image, we are continuously scanning it and looking for certain patterns. This system is quite fast but prone to errors. It works through shortcuts, impulses, and our gut feeling. And then we have a second system. We all use it for all things cognitive, including visual analysis of radiological images. This is our slow thinking, and this is a system we only use when we need it. We use it to solve specific problems, and it takes time and effort to solve these problems by using the slow thinking system. So it's a slow system, but it is more reliable than the fast thinking system. Now, radiological images belong to system one. We look at something and we immediately recognize a certain pattern or a certain resemblance of what we see on our images to something we know from real life. As a consequence, it's also prone to errors. But this is what this presentation is going to be: fast thinking and radiology. So this is slow thinking. There are a lot of presentations on this channel, and most of them basically are about slow thinking, because in it we talk about, let's say, imaging of brain tumors, how to analyze them, and that's always systematic. It's always based on a systematic analysis. It starts with a structured search pattern. You look at your images in a systematic way, and then you just go, you follow certain checklists to be sure you didn't miss anything, and it's basically decision tree radiology. If you see a tumor and the tumor is located over there, and it looks like that, and the patient has a young age or an old age, or as a man or a female, whatever, then your final diagnosis or differential diagnosis is that. This is the slow way of doing radiology, but I'm going to talk about the fast way, the fast visual analysis, the fast thinking in radiology, which in psychology is known under the name Gestalt analysis. And what is Gestalt? Well, when you look at this slide over here, you all can read the word Gestalt, I'm sure of it, despite the fact that none of these letters are actually complete or normal letters. So we immediately recognize the letters despite the fact that something is off or something is wrong with them. Gestalt means recognizing patterns. The whole is more than the sum of its parts. So we see that the letter G is composed of 3 patterns. Individually, they don't resemble anything, but we kind of combine them to the letter G in our head. This is basically Gestalt. That's also what happens in radiology when we look at a scan and immediately recognize a pattern or even a certain diagnosis without having analyzed the images in detail. And what we're going to show in this presentation are those kind of diagnoses. We look at the images and we really say it's going to be this or it's going to be that, based on, well, just the fact because it looks like that. And there's even a word for such a diagnosis in radiology. That's an Aunt Mini. So an Aunt Mini in radiology is basically a pathognomonic case. It's based on something that was written once by the thoracic radiologist Benjamin Felsen. If you see a woman walking down the street and she looks like your Aunt Minnie, she talks like your Aunt Minnie, she behaves like your Aunt Minnie, she is your Aunt Minnie. So you don't need to check her driver's license, you don't need additional proof to know that she is Aunt Minnie. And the only person who will probably disagree with that is going to be the psychiatrist Joseph Capgras. If you don't understand this joke, please look up Capgras syndrome. So that's an Aunt Minnie. We know Aunt Minnies in radiology. We often use them. It's what happens when we are at a multidisciplinary meeting and you say, oh, this is a meningioma. Then somebody asks, why is it a meningioma? And you're like, I don't know, just because it looks like a meningioma. So we immediately recognize it without having really analyzed it consciously. Now, a bit similar in radiology, we use a lot of these as well, are pareidolias. What are pareidolias? The human tendency to see meaningful patterns like faces or objects in random or ambiguous visual stimuli. And what you see here on this image, that's a mountain or a hill or a crater. I don't really know, would have to look it up. I think it's some kind of mountain on the planet Mars. But because of the way that the image is made and the light falling on the structure, it kindly resembles a face. So we all recognize a face in it, despite the fact that this is not a face. And that's what a pareidolia is. And well, many classic signs in radiology are pareidolias. We are going to see a lot of signs called like the panda sign or the hummingbird sign, because we are looking at something on our scan that looks like a hummingbird or looks like a panda, something like that. And we're going to encounter a lot of animals in this presentation. So without much further ado, this was the introduction. Let's jump right into it. We're going to talk about gestalt. We're going to recognize immediately certain patterns and structures without analyzing the scan in detail. And these can be Aunt Minis and these can be radiological signs. And the majority, well, radiological signs are in a way like Aunt Minis. There's some overlap between the two concepts. And I made a division based on the kind of pathology. So we're going to talk about signs concerning neuroradiological tumors, vascular pathologies, infectious and inflammatory diseases, toxic, metabolic, congenital, and degenerative. And we're going to start with tumors. And you notice that I'm really talking fast because this is about fast thinking, and this is also about fast analysis. We're going to discuss 10 signs or ontogenies in this presentation, and let's start with one we all know, the butterfly tumor. A butterfly tumor, as you know, is a tumor located along the midline, centered in the corpus callosum, spreading in both cerebral hemispheres. And if you use your imagination, you can see two butterfly wings and then the body of the butterfly in the middle. This is a sign we classically associated with glioblastomas, the so-called butterfly glioblastomas. Glioblastomas are the most malignant primary brain tumors in adults, and they preferentially arise in the deep white matter. And when they arise in the white matter of the corpus callosum, they can have this configuration and then spread in both cerebral hemispheres. And here we see some examples, and glioblastomas are typically central necrotic tumors, as you see on these images. The main differential diagnosis for a glioblastoma would be a metastasis, but metastases rarely arise centrally in the corpus callosum. Nothing is impossible in radiology, but this belongs to the world of case reports. So I looked up some case reports on metastases that have a butterfly tumor appearance, and I didn't find many. So these are just two examples, while when it comes to glioblastomas, this is a not infrequent pattern. So a more important differential diagnosis for a butterfly tumor is not metastases, but would be lymphomas. Lymphomas are less frequent than glioblastomas, but also have a predilection for the periventricular white matter, so they also often arise in the white matter of the corpus callosum and can then spread into both cerebral hemispheres. And here are some examples of butterfly lymphomas, but there is an important difference between CNS lymphomas and glioblastomas. Well, there are multiple, but I'm just going to focus on one, and that is that lymphomas have a homogeneous pattern of enhancement in the large majority of cases, while glioblastomas almost invariably have areas of central necrosis. So the distinction can, based on this characteristic and some others, often reliably be made, despite the fact that they can arise in the same location. Another typical pareidolia or sign associated with a specific tumor is the following. We see here a large tumor arising from the sella turcica. This is a pituitary tumor which has extended through the diaphragm sellae and the suprasellar cistern. And if you use your imagination, this looks a bit like a snowman sign or a snowman. It's called the snowman sign, and it is classically associated with macroadenomas of the pituitary that extend from the sella turcica into the suprasellar cistern, and the impression caused, or the waste here, is caused by the diaphragm sellae through which the tumor has to extend to reach the suprasellar cistern. Okay, let's now talk about an Aunt Minnie. There is no radiological sign associated with this tumor, but I'm showing it to you anyway, because this is one of the few primary brain tumors we can reliably diagnose on an unenhanced CT of the brain. We see here a hypodense tumor, and located within the tumor, we see some chunky calcifications. The tumor is located in the left frontal lobe and seems to arise in the cortico-subcortical transition area. This combination of findings is very characteristic for one specific tumor, namely an oligodendroglioma. So if you see this, a tumor located supratentorially, often in the frontal lobe, not always, but often, seeming to arise from the cortico-subcortical region, and especially with these very large, coarse, chunky calcifications, think oligodendroglioma. It really is one of the few brain tumors we can almost very confidently diagnose with near certainty. Nothing is 100%, but with high certainty on an enhanced CT of the brain. Here we see some other examples of pathologically proven oligodendrogliomas, and in these patients the diagnosis was each and every time suggested on the unenhanced CT of the brain. We see here a cluster of chunky calcifications and some distortion of the brain parenchyma over here. This tumor we've seen on the previous slide, and also a typical, well, not typical, but also not infrequent, oligodendrogliomas have very fragile chicken wire capillaries, so they are prone to rupture these capillaries, and oligodendrogliomas can present with hemorrhage. Now, if you see this, it would be difficult to see the underlying tumor in a normal situation on an unenhanced CT of the brain, but we see the coarse calcifications medially of the hemorrhage, which immediately made us suggest that this is a tumoral hemorrhage in a patient with oligodendroglioma, and also in this case, our guess was correct. This is a classic Aunt Minnie of a very rare tumor. And this is a case where these radiological signs can be very handy, because when it comes to rare pathology, we don't encounter these kinds of tumors enough to have a good feeling of their typical imaging appearances, but if they're associated with an Aunt Minnie or a radiological sign, they are very easy to remember. You just have to have seen them once, and the next one will look very similar. This is a tumor with a striated pattern, or a tiger striped pattern. And if you see these tumors in the cerebellum, think Lermite-Duclos disease. What is Lermite-Duclos disease? It's also known under the name dysplastic cerebellar gangliocytoma. It's a benign tumor. It's a neuroglial tumor, meaning it's a tumor composed of both neoplastic neural cells and glial cells. It's typically located in the cerebellum. It's very benign, and it classically has this striped pattern, this tigroid pattern on T1 and T2 weighted images, and generally shows no or very little enhancement, as you can see on these MPRH images with gadolinium. Other authors believe that the tumor has a more laminated pattern and have likened it to corduroy fabrics, as you can see here. Whatever, as long as it sticks with you, that if you see a tumor with this pattern in the cerebellar hemispheres, think Lermite-Duclos disease or dysplastic cerebellar gangliocytoma. This brings us to a very frequent sign, and I believe one of the most important signs in neuroradiology, the CSF cleft sign. What's the CSF cleft sign? It's a cleft filled with cerebrospinal fluid between a tumor that has arisen outside the brain parenchyma and the actual brain parenchyma. And if you see this sign, this cleft of cerebral fluid lining a tumor, separating tumor from brain parenchyma, you can be absolutely certain that this is going to be an extraaxial tumor. And the most frequent extraaxial brain tumor, as you know, is a meningioma. Here we see some additional signs, some widening of the CSF space between the tumor and the brain parenchyma. We see a displaced vessel in the CSF cleft, and we see some flattening of the cerebral cortex underneath the tumor. But of all these, the CSF cleft is the most specific sign to determine if a tumor is intra or extraaxial, and this is basically the first thing you have to do when you see a brain tumor. Determine if the tumor is located intra or extraaxially. Here we see some additional examples of meningiomas, each and every one associated with a very typical and classical CSF cleft sign. This brings us to still the CSF cleft sign. It's not limited to T2 weighted sequences. You can also recognize it on FLAIR sequences, T1 sequences, basically any sequence. So look for it if you're dealing with a brain tumor. Another sign often associated with extraaxial brain tumors, and more specifically meningioma, is the dural tail sign. What is a dural tail sign? It's enhancement located immediately next to a brain tumor, enhancement of the dura immediately next to a brain tumor. And this enhancement typically has a somewhat different intensity of enhancement compared to the actual tumor, and tends to taper from medially to laterally, or from immediately close to the tumor to far away from the tumor. So it tends to thin out. So these are two examples of meningiomas associated with a dural tail sign. Now, important to know, and this is also, you can also guess that because the intensity of the dural tail is not the same of the actual tumor, this is not tumor. These are reactive vascular changes in the dura immediately next to the tumor. You don't see it in all meningiomas. You see it in about 60%. So it's definitely not as useful for proving a lesion is located in the extraaxial space as the CSF cleft sign. This dural tail sign can be very small, or it can be quite extensive, so it can do all things. And very important to keep in mind, it is not pathognomonic for a meningioma. It is not even pathognomonic for an extraaxial tumor. Yes, we often see them in meningiomas. We often see them in extraaxial tumors, whether they are meningiomas or others, but you can see them in basically any superficially located tumor that makes contact with the dura. This patient over here has a dural tail, but the tumor is located inside the brain parenchyma, is central necrotic, and this is a glioblastoma. So remember, the dural tail sign is not pathognomonic for meningioma. It can be seen in other tumors. And something we often see when it comes to all minis and radiological signs is that when they are first described, they are often described in just a few patients or in a case report, and it is often said or assumed that this sign can be extremely reliable or almost pathognomonic for a certain entity. And then you get some follow-up studies that say, well, that's not really the case. You can see it in other stuff as well. So it's not as reliable as initially believed, but it's often the initial study that keeps being quoted in review articles or textbooks. So be very critical. So the dural tail sign, for instance, is not pathognomonic for meningioma. It's not even reliable for the diagnosis of a meningioma. Here are two additional signs that you can see in meningiomas. You rarely need those to have the diagnosis. There are a lot of other more defining characteristics, but these signs have proven useful to me in cases where there was doubt. And what are these signs? They have to do with these very small lines we can see extending from either the center of the tumor to the periphery. And if we see that, we call it the spoke wheel sign. So I'm removing the sign every now and then to make you appreciate the sign, because the lines can maybe a bit subtle, but I hope you see that there's a center here. We see some small dots. These are vascular structures, and then we see some lines extending from the center to the tumor. And we have a similar phenomenon. This is a T1 weighted image with gadolinium. We can see the same phenomenon on T2 weighted images, where we see here a tumor located extraaxially. We see a CSF cleft sign, and we see all these lines extending from this part, this focal area over here, immediately next to the skull. What are we looking at? We are looking at vessels radiating from a dural pedicle, which brings in vessels from the external carotid artery that supply the tumor. And these vessels radiate from the center of the tumor or from this dural pedicle to the periphery of the tumor. Another vascular sign, often described in meningiomas, but let's say more not officially, I don't think it's an official sign, is the following. So here we have a patient with a large meningioma. It's a very large, almost homogeneously enhancing tumor with a lot of edema in this case. And the sign I'm going to show you is called the mother-in-law sign. It's classically described on angiography. And what is the mother-in-law sign? It basically means that if you do an angiography, and here we see an angiography, sagittal images, these are external carotid artery vessels, which an angiography made from within the external carotid artery. We see an early contrast blush. So this blush comes early, but it also stays late. So we are now looking at images in the venous phase, and we still see an intense blush. So this pattern, an enhancement on angiography that comes early and stays late, is by some people referred to as the mother-in-law sign. Final sign when it comes to brain tumors is the following. Here we see a patient who had visual loss of the left eye with extreme hyperdensity lining or within the left optic nerve. Let's look at our bony window and we see what looks like calcifications lining the optic nerve. If we look at coronal images, okay, we're clearly looking at calcifications that are lining the left optic nerve. When we look again at the magnified axial images, this pattern kind of resemble tram tracks, and this is called the tram track sign. It's classically seen in optic meningiomas. The optic nerve is also aligned by meninges. So as a consequence, you can have meningiomas of the optic nerve, and meningiomas often calcify. When that happens, in a meningioma lining, the optic nerve, we get the so-called tram track sign. And I find it a useful sign because you can have all kinds of pathologies involving the optic nerve. You can have also glial tumors. You can have optic nerve gliomas. You can have an optic neuritis. And in some cases, it's not always clear if a thickening of the optic nerve is caused by this or that tumor or by neuritis or something else. So there have been cases where I suggested maybe do an enhanced CT when it was really necessary for the correct diagnosis, do an enhanced CT, because if you see a tram track sign, this is very specific for an optic nerve meningioma. You don't see that in optic nerve gliomas. You don't see that in inflammatory disorders of the optic nerve. So we don't often see it, but when we see it, I find it a reliable sign. This brings us to part 2 of this presentation, vascular radiological signs and Aunt Minis. In the second part of our presentation on imaging of neuroradiological signs and Aunt Minis, we are going to see quite a lot of them. I'm not going to go over them right now because that alone would take me a minute, but we're going to talk about a total of 24 neuroradiological signs and or Aunt Minis in the world of vascular neuroradiology. And these, I'm pretty sure most of you will all know already, the 3 signs classically associated with an acute ischemic stroke. We have the disappearing basal ganglia sign, the disappearing or the loss of the insular ribbon sign, and the hyperdense middle cerebral artery sign. Let's nevertheless look at these signs in a bit more detail because they are so tremendously important. The disappearing basal ganglia sign is a sign classically associated with a large vessel stroke of the middle cerebral artery and involves disappearance of the basal ganglia, because the lenticular-striate arteries arise immediately from the main trunk of the middle cerebral artery, and the lenticular-striate arteries supply the basal ganglia. The basal ganglia are extremely vulnerable to early ischemic infarction in case of a middle cerebral artery stroke. Now, the disappearing basal ganglia sign can sometimes be a bit tricky. It can be subtle. What helps is to window our images to generate some more contrast between gray matter and white matter as I have done on the image on the right side of your screen. And if we now compare the normal left-sided basal ganglia, well, we immediately recognize that these are absent on the right side. And if you've seen it a couple of times, you don't need to window anymore. You just have to look for it in each and every patient with a suspicion of a large vessel arterial stroke. So this is the disappearing basal ganglia sign, and a bit similar is the loss of the insular ribbon sign. The insula is also supplied by penetrating insular arteries. These arteries supply a region that is probably the farthest removed from collaterals of the anterior and the posterior cerebral arteries, making this region also quite vulnerable to early ischemic changes in the case of a middle cerebral artery stroke. And what does the loss of the insular ribbon sign look like? Well, let's compare the right insula, where we see a normal insular cortex, with the left insula, where the cortex has diminished in density so much that there is almost no difference anymore between the cortex and the subinsular white matter. There is loss of the insular cortex, so we call this the loss of the insular ribbon sign. In this patient over here, we see a lot of streaking artifacts, but that's what happens in daily life. We often are confronted with images like these because there's a lot of stuff laying next to the head of the patient, sometimes not to be avoided. But in this patient, nevertheless, we can recognize both signs. Let's first look at the basal ganglia. We see, when we compare the left side with the right, that there is a partial disappearance of the left lentiform nucleus. And if we now compare the right insular cortex with the left side, well, there is also loss of the insular ribbon. So this was a patient with a complete occlusion of the middle cerebral artery, and when patients have that, sometimes we can see the thrombus on unenhanced images of the brain, and when that is the case, we call it the dense artery sign. Look at how dense that is, but remember, this sign is not present in all patients with an occlusion of the middle cerebral artery. It's only seen in about 30% of patients, so you can't rely on it for the diagnosis. You still need a CT angiography. Depending on where the occlusion is located, we can also call the dense artery sign more specifically the dense MCA sign, when it is located in the main trunk of the middle cerebral artery. Sometimes the occlusion is more peripherally located and a smaller branch, then we can call it the dense M2 sign or the insular dot sign, when it's located in a small branch located in the insula. Now, it's the same sign, dense artery sign, and then there are some small variations in the name based on the exact location of the sign. And that's something that we will also encounter in the following signs that are described in patients with cerebral venous sinus thrombosis. In these patients, there are a lot of signs available to describe the appearance of the thrombosed veins. Now, when you have a thrombosis of the veins, the density will also increase, similar to having a thrombosis in one of your cerebral arteries. And we call it the dense vein sign, so that's easy. And here we see a very dense superior sagittal sinus and also some dense cortical veins. Now, depending on the location, if it's located posteriorly in the superior sagittal sinus, you can also call it the dense delta sign. If it's located in the transverse sinus, where it looks a bit more like a cord or a tubular structure, it is called the cord sign. And if you see absence of contrast opacification in the posterior superior sagittal sinus on a CT angiography or venography, it's called the empty delta sign. So a lot of different names, but all implying the presence of a cerebral venous sinus thrombosis. And let's also in this case look at some of these signs in a bit more detail. Let's start with the general name, the dense vein sign, a name given to any pathological hyperattenuation of a dural sinus and or a cortical vein due to an inlying thrombosis. But when is hyperdensity of the cerebral veins pathological? Because we all know from daily radiological practice that the veins are often a bit dense, yeah, and it can make it a bit difficult. Well, it can be quite difficult. So in some cases, they are so dense that even upon simple visual analysis, you think like, oh my God, it's way too dense. This is going to be a thrombosis, especially if there's also a corresponding clinical context. If that's not the case, measure the density. And I start getting suspicious if my density is higher than 70 Hounsfield units, and especially if it's higher than 80 Hounsfield units. But as soon as it's higher than 70, I'm probably going to pick up the phone and maybe talk to my neurologist from, hey, could this be a cerebral venous sinus thrombosis, and don't you want to do a CT venography to confirm it? Now, this is the dense delta sign, but some also call it the dense triangle sign. And this is something we will often encounter in radiological signs. Sometimes you have different names to refer to basically the same pathological entity. So the dense triangle sign or the dense delta sign, it's all or both referring to having a thrombosis in the posterior part of the superior sagittal sinus. So this is the same patient, and this is the Greek letter delta, so we can also call it the dense delta sign if you want to. This can sometimes make the world of radiological signs a bit confusing, if you ask me, because it's like a sport in radiology to, have your own sign published. So I often refer to the delta sign as a sign involving a thrombosis of the posterior part. That's because the anterior part doesn't really look like a delta, or it looks like an inverted delta. And I'm not the only one who noticed that. Others noticed it as well, but then decided to publish it as a new sign and call it the dense inverted triangle sign. Now, if you ask me, we are, reaching a point where it starts to become a bit ridiculous. That's for starters. Just call all of them dense vein signs and be over with it. And if you nevertheless want to introduce a new sign to the world of radiological literature, publish it in a radiological article, preferentially a big one like Radiology, and not in the Japanese Journal of Internal Medicine, because chances are slim it's going to be picked up by the radiological community. Now, this is all a bit in good fun, but if you look for it, you see that there are a lot of these one-hit wonders, or, these cases where a new sign was published and, never got track or never found its way into the radiological community. And some of them can be a bit fun, if you ask me. Now, let's look at the empty delta sign, which is a sign described on venography, can be on CT or MRI, and it basically refers to the absent contrast opacification of the central part of the superior sagittal sinus aligned by the enhancing dural membranes or the enhancing dura surrounding it. So the empty delta sign. That's enough, I'd say, but nevertheless, we still have to go over the chord sign. And that's basically a dense vein sign. You can use it when the vein in question looks a bit more tubular or more like a cord, originally described in the transverse sinus, but you can also use it for thrombosed cortical veins when it looks a bit tubular or cord-like on your unenhanced CT. Okay, we're ready to talk about something else. And this one, I actually kind of like this pattern. Now, on the background, we see the universe. We see billions of stars over there. Well, probably not on this specific image, but there are billions of stars in the image, and the universe, I mean. And this is a susceptibility-weighted image of a patient with a specific entity. We see a lot of very small black dots corresponding to microhemorrhages. And we also see on the diffusion-weighted images of this very same patient a lot of tiny areas of diffusion restriction, a lot of tiny infarctions. This is the classical pattern of a cerebral fat embolism. Chances are high that this patient has a fracture of a long bone, and small emboli have embolized into the brain, causing these tiny infarctions and tiny hemorrhages. It's a pattern called the star field pattern. And cerebral fat embolism is not something we encounter on a daily basis. So this is also an example of a pattern I find very useful to come to the diagnosis in the right context, because you can have a star field pattern in basically any embolic situation, not just in cerebral fat embolism, but it will never be as extensive in my experience as when you're dealing with cerebral fat embolism. Okay, so probably what to remember. Also, a nice one is this one. We see an area or basically a linear streak of small infarctions located in the deep white matter of the left corona radiata. And this looks a bit like a necklace, pearl necklace. So it's called the string of pearls sign. It's something you can see in internal watershed infarctions. And this leads us to something else we encounter in the world of neuroradiological science. That's something that can also be a bit confusing. That is, well, the fact that sometimes the same sign can be used for different pathological entities. Here we see some neuroradiological signs on angiography, digital subtraction angiography, and the string of pearls sign or the string of bead sign can also be used to refer to this here. We see these small, let's call them impressions in the walls of the internal carotid artery over here. This is the classical sign of fibromuscular dysplasia. In this patient, we see a total occlusion of the carotid head, and then we see what looks like a puff of smoke caused by lenticulostriate collaterals. This is a classical angiographic sign of Moya-Moya disease. And over here, we see an abruptly ending contrast opacification of the internal carotid artery, but it's abrupt and not abrupt. It's basically not abrupt. We see more tapering, and this tapering looks a bit like a flame. This is the flame sign, and it's classically seen in internal carotid artery dissection. This is the puff of smoke sign again. So Moya-Moya disease is a chronic disease involving often the large proximal arteries of the anterior circulation, being the carotid head or the main trunk of the middle cerebral artery, the anterior cerebral artery, so the proximal parts. And these chronically narrow, stenose, sometimes even occlude. But because it is a chronic disease, the brain gets time to develop adaptation mechanisms. So sometimes a lot of collaterals are recruited through the lenticulostriate arteries, and these can have the appearance of a puff of smoke. Moya moya is Japanese for puff of smoke. So it's first described in Japanese patients. And this here is a comparison with a cigarette, and the top of the cigarette would be the occluded or the stenosed carotid top, and this is then the puff of smoke. So we can see where the name comes from. Now, on angiography, I think it's a bit more difficult to recognize in those collaterals a puff of smoke. This is a really 3D TOF angiography in a patient, a 3D TOF angiography in a patient with Moya-Moya syndrome. And we see here all these tiny collaterals in the basal cistern area, but that doesn't really look like a puff of smoke over here. This is a patient with an internal carotid artery dissection, and we see a very nice flame sign. And I find the flame sign quite useful because when it comes to an internal carotid artery that doesn't opacify, there are three possibilities. Either the patient has a total proximal occlusion, and these are often atherosclerotic. So often you see a very abrupt occlusion, and you often also see calcifications in that region because this is often a chronic atherosclerotic plaque that has completely occluded. It can also be the result of a carotid top occlusion. And in that case, you will also get tapering of contrast in the internal carotid artery, but it will look more like a horizontal line. You won't see it taper like this upwards, giving it the image of a flame or leading to the flame sign. So this is probably not 100% specific or pathognomonic, but nevertheless quite useful in my experience for the diagnosis or the suggestion of an internal carotid artery dissection. And here we have another example, very nice flame sign of carotid artery dissection. So I believe this is what you should also know or remember. Let's now look at some Aunt Minis and radiological signs involving vascular malformations of the brain. Let's look at popcorn lesions, let's look at brainstem clouds, and let's look at some snakes and palm trees. And we're going to start with the popcorn lesions. Here we see a lesion which, if you use your imagination a bit, looks like a popcorn. And this is a very typical appearance on T2 weighted images, but you can also see it on T1 weighted images of a brain cavernoma or a cerebral cavernous malformation. These are slow flow vascular malformations of the brain. They are not infrequent and they can hemorrhage. Basically, the lesion is composed of multiple small sacs containing blood of various ages. So the blood is so slow flowing that it can thrombose, and this leads to the heterogeneous imaging appearance and like popcorn-like appearance on T2 weighted images, and can also have a similar appearance on T1 weighted images, but I appreciate it more on T2. Some authors liken it to mulberries rather than popcorn. It's a matter of personal preference, I believe. These are some other examples, and you can see that this is a recurring imaging pattern that makes cavernomas, in my experience, quite easy to recognize. So this is an Aunt Minnie for me, a classical popcorn lesion. This is also an Aunt Minnie. Here we see some cloudy enhancement centrally within the brainstem. If you see this, you have to look at your other sequences as well before you give the diagnosis, but I already will have a strong idea in this patient. If you look at the T1 weighted images with gadolinium, we see like the cloudy enhancement. We see signal loss on the susceptibility weighted images, but it's not blooming because the area of signal loss is identical to what we see on T1 weighted images with gadolinium. And blooming, it will look bigger. And we see nothing at all on the FLAIR images. This is almost pathognomonic for capillary telangiectasia. And capillary telangiectasias are very benign vascular malformations. They're basically a congenital, probably congenital widening of the capillaries, often in the brainstem, but it can occur anywhere. Because these capillaries are a bit leaky, you get faint brush-like or cloud-like enhancement. And because they are filled with slow-flowing venous blood with a lot of deoxyhemoglobin, which is slightly paramagnetic, you will get a signal loss on susceptibility weighted images and T2 star images. But very important, you will have no abnormalities on your T2 or FLAIR images. So if you see this combination, this is going to be a capillary telangiectasia. And it's important to know these because I've seen multiple patients who were referred for a second opinion, and nothing wrong with that, because of suspicion of a brain tumor, because an area of enhancement was seen within the brain, which upon immediate inspection, it was clear that this was a benign capillary telangiectasia. So you don't have to make these patients worried about having a brain tumor if you can give them immediately the exact diagnosis. So definitely one you should know as well. And this one as well, snakes in the brain or palm trees in the brain. This is the imaging sign classically associated with developmental venous anomalies, which are congenital abnormalities of the venous drainage. Well, abnormalities more like a variant pattern of venous drainage, which can be considered normal. These lesions typically consist of a collector vein, and then we have a lot of smaller veins contributing to the collector vein. And these small veins that basically drain in the collector vein can look like the snakes situated on the head of Medusa, or they can look, depending on how you look at it, like a palm tree. So also here, personal preference or depends a bit on what the exact lesion looks like. The main thing is that you're able to recognize it for what it is, a developmental venous anomaly, which is not to be confused with an arteriovenous malformation. Here's another example. Let's rotate this image a bit, and you can see both of them if you ask me. So here we have the smaller veins draining in the collector vein, and you can either consider that the stem of the palm tree, and these that you can consider it a palm tree sign, or you can nevertheless still say this is going to be the face of Medusa and consider it a caput Medusae sign or a head of Medusa sign. As said, do not confuse it with arteriovenous malformations. And for me, especially larger arteriovenous malformations also are aunt minis because they typically or can be compared to a bag of worms. You have the nidus, which is a conglomerate of these plastic vessels. This is basically the center of the arteriovenous malformation. And this cluster of flow voids, this cluster of these plastic vessels can be compared or likened to a bag of worms. If you see that, think arteriovenous malformations and do a tough angiography to confirm because these are arterial structures and developmental venous anomalies will have no arterial flow whatsoever. So you would still be having doubts. Let's now talk about some signs associated with hemorrhages. And let's start with one you can frequently encounter because it is my philosophy that every patient with a primary hemorrhage in the brain, so a non-traumatic brain hemorrhage, should receive a CT angiography to rule out underlying vascular malformations. Now, if the hemorrhage is hypertensive, no vascular malformations will be present, but we can nevertheless see something else called the spot sign. So the spot sign is basically leakage of contrast in a hematoma. It is a sign that the hematoma is still actively bleeding. So it's associated with hematoma expansion and a worse prognosis, which kind of makes sense. We basically are looking at a hematoma that is actively and arterially bleeding and expanding. And this is the area in which the spot sign is located. And we see that the hematoma is largely hyperdense. So this corresponds to clotted blood, but this is the unclotted component. Unclotted components in a hematoma have also been described in epidural hematomas and have received a very a well-known name. Let's look at this epidural hematoma. So we see in the periphery hyperdense clotted blood, but then we see this central component which is heterogeneously iso or hypodense. And this corresponds to also active hemorrhage within the hematoma. So this patient is still actively bleeding. Epidural hematomas are also, in the majority of cases, arterial hematomas. And this sign is called the swirl sign. And it's a sign of active hemorrhage. Now, there's no reason why we shouldn't also call this a swirl sign because it basically boils down to the same concept. And we can call it a swirl sign. But in the world of neuroradiological science, some authors even went a step further and invented a new sign for this appearance because it is so hypodense, they believe we should call it a black hole sign and not just a swirl sign. Now, where lies the difference? Well, the authors of this publication said, well, if you have a density difference of at least 28 Hounsfield units, and once again, in my opinion, we have reached the world of the ridiculous because, well, when we're talking about radiological science, you want something that you just have to look at and say, oh, it looks like this or that. The minute you have to start measure things, you're no longer working with radiological science, in my opinion, to be honest. And you're measuring stuff, and that's a whole different approach. You're starting to use the slow system, not the fast system of visual analysis. But that's just me. So no, it exists, the black hole sign. And also visually, it looks so dark. Definitely there's going to be a density difference of more than 28 because this looks like fluid, must be like 0 or in the neighborhood of 0, and this is blood, so this is like 60 to 100 or so. Okay. Another sign associated with hematomas is the following. Sometimes you can see in the vicinity of the bulk of the hematoma, so the main hematoma, we can see a smaller hematoma, and this is called the satellite sign. And the presence of a small hemorrhage adjacent to but separate from the main hematoma is also a moderate predictor of hemorrhage expansion. But if you see multiple spots, there's another name for that. We call it the island sign. We have to see at least 3 small hematomas, either immediately connected to the hematoma or 4 sprout-like branches of the main hematoma. Once again, if you see that, it's also associated with hematoma expansion, active hemorrhage, or worse prognosis. But if you ask me, we have also entered a bit the world of the ridiculous because we have to start looking at how many hematomas or how many sprouts we see, and that's basically we're starting to analyze this quantitatively. And this is not a true sign, in my opinion, despite the fact that they have given it a sign name. But once again, just me, personal preference. This one is a true sign, and it's also one of those nice ones because it's a rare entity, but it has such a typical appearance that if you recognize the sign in the appropriate clinical context, you have a diagnosis. This is a patient who clearly has tissue loss, old tissue loss, and the right temporal lobe. This is the result of an old surgery. And we also see a recurrent tumor located in the frontal lobe. Patient underwent surgery for the recurrent tumor, and on the images after surgery, we see a striped hemorrhage. This is a subarachnoid hemorrhage located within the fissures of the left cerebellum. This stripe pattern has been compared to the stripes of a zebra and is called the zebra sign. And if you see the zebra sign, this is suggestive for what is called a remote cerebellar hemorrhage. Remote cerebellar hemorrhages are hemorrhages that occur in or around the cerebellum and are often seen after supratentorial hemorrhage surgery. And it's a bit bizarre because why does the patient develop a hemorrhage in the cerebellum if he has been operated somewhere completely else in the supratentorial compartment? The reason for that is a bit unclear. It is believed it has to do with loss of cerebrospinal fluid during the surgery, causing some traction or some sagging of the brain, maybe leading to maybe some rupture of veins. There are different hypotheses. Whatever the cause, the main thing is these are generally benign hemorrhages. They resolve spontaneously. And if you see this pattern, you can also kind of reassure your surgeon. It looks strange. Yeah, why does the patient develop this cerebellar hemorrhage? But it's a known entity, remote cerebellar hemorrhage, and can be easily recognized with the zebra sign. And that concludes the extensive list of 24 neuroradiological signs in the world of vascular radiology. Let's move on to the next topic, inflammatory and infectious diseases of the central nervous system. So these are the signs and minis we're going to discuss. I'm not going to read them out loud. Let's just look at the images. And I'm going to start with some, well, I don't really know if we can call them signs or if they're more like minis. I'm going to show you some very typical imaging findings that should make you think multiple sclerosis. Now, you see that the title of this slide is called Beyond McDonald. We know the McDonald criteria. We use them in each and every patient suspected of having multiple sclerosis or if there's a follow-up of multiple sclerosis. But there are situations in whom there is no clinical suspicion of multiple sclerosis, and in whom we don't immediately use them, but in whom nevertheless signs can be present that should make us think multiple sclerosis. And what are those? Well, first of all, the typical Dawson fingers. We have the black holes and we have the open ring or the horseshoe enhancement. Let's look at Dawson's fingers. What are Dawson's fingers? Those are periventricular white matter lesions. Now, white matter lesions are not infrequent in the general population, and we see more of them as we age. They often have a microvascular origin, especially in older patients, and they can also in older patients be located in the vicinity of the ventricles. But if your periventricular lesions are located almost perpendicular on the surface of the lateral ventricles, that's very suspicious for demyelinating plaques. These are periventricular white matter lesions that are located along the periventricular venules, and demyelination typically occurs along venules. And if you see this morphology, think multiple sclerosis. Here we see Dawson, one of the characters from the 90s series Dawson's Creek, and these are his fingers. Now, the lesions are not named after Dawson from Dawson's Creek, but after a radiologist or a pathologist, I'm not really sure, who first described this morphology. Let's move on to the next characteristic on imaging that you should know and should make you think multiple sclerosis. Those are the so-called black holes. Demyelinating lesions, especially chronic demyelinating lesions, can be very dark on T1 weighted images. That's why we call them black holes. And this is quite typical for multiple sclerosis. And I have seen cases in whom patients older patients, but older patients can also have multiple sclerosis, had a lot of white matter lesions, and because microvascular disease is so prevalent in the older population, this was considered microvascular white matter disease. But this patient also had a lot of black holes. Now, you can have old lacunar infarctions, and these will also look like black holes, but when you have a lot of them, and especially when they are located immediately along the ventricles, that looks more like the black holes of multiple sclerosis. So if you have a lot of holes in the brain and these holes are black, think multiple sclerosis, because these are very suggestive for multiple sclerosis. And if you don't believe me, I'm going to compare these images with those of a patient with classical microvascular white matter changes. Here we see the FLAIR images. We see a lot of microvascular white matter changes. We see these changes along the ventricles and in the deep white matter. But if you look at the T1 weighted images, we don't see black holes. So as said, you can have black holes if you also have some old lacunar infarctions, but that will mostly be one or two old lacunar infarctions, not a lot, and not located immediately along the ventricles. The next sign that should make us think demyelinating disease is the open ring sign or the horseshoe enhancement sign. And that is something we typically see in demyelinating lesions. So here we see a T1 weighted image with gadolinium. This is a demyelinating plaque located along the cortex. So it's a juxtacortical lesion. And we see the typical open ring enhancement with a rim of enhancement located towards the centrum of the brain or located medially. And for comparison, a few other demyelinating lesions. So in the majority of cases, we will see the ring at the inner side of the brain. Here are some other lesions. Here the pattern is reversed, but that has to do with the fact that this lesion originated along the ventricles. So the point of origin is probably along the ventricles. So this is the active zone of demyelination. Item here, but here the point of origin is probably the juxtacortical white matter. And here we see several demyelinating white matter lesions, and we can also see them in the spinal cord. So this is a patient with demyelinating lesion in the spinal cord with the typical open ring sign or the horseshoe enhancement sign. So are these pathognomonic for multiple sclerosis? Well, true pathognomonic signs or alt minis are actually quite rare, I think. You never reach 100%, or you at least also have to keep an open mind. So there's a reported specificity for open ring enhancement for demyelination of 80 to 99%. So those are good odds. The sensitivity, however, is a lot lower. So if you don't have the sign, it basically doesn't mean anything. And it makes sense because you have multiple sclerosis lesions with no enhancement or maybe an other pattern of enhancement. So it's a strong diagnostic clue in favor of demyelination, but it's not definitive. Okay. Then let's move on to three alt minis. So three very typical patterns or signs that can lead you to the correct diagnosis provided you know them. And entities are actually quite rare. And this is where I find these alt minis or these radiological signs very handy. Let's start with this lesion. We see on the sagittal T2 weighted image an abnormality located in the parieto-temporo-occipital transition area. And if you look carefully, this lesion looks a bit like an onion bulb or an onion skin, and it's called the onion bulb sign. And it's a pattern that is associated with a specific demyelinating disorder. Let's now magnify this lesion a bit so you can appreciate it a bit more. It looks like an onion, right? So hence onion bulb sign. And it's a disease first described on pathology in the 40s by a Hungarian pathologist called Joseph Ballo. It's a tumefactive demyelinating lesion, and the rings are caused by areas of demyelination alternating with areas of reserved or preserved myelination. So this is Ballo's concentric sclerosis. And this is a rare form of demyelination, but the imaging pattern is so typical that this can lead you to the correct diagnosis. Another similar disorder is the following. Here we see a a patient with an area of edema. And this area of edema is located in the left thalamus and extends in the left cerebral peduncle of the midbrain or the mesencephalon. And this looks a bit like a waterfall or a cascade, and it's called a cascade sign. And this should make you think neuro-Behçet disease. Will this always be neuro-Behçet disease? No, this can be a small metastasis surrounded by edema. And if the metastasis is located in the thalamus, it can have this same pattern. But if you're dealing with a patient with, for instance, Turkish roots or originating from somewhere along the old Silk Road, and you see this pattern of edema and you have no real explanation what you're looking at, think neuro-Behçet. Neuro-Behçet is a rare inflammatory disorder, at least in my part of the world. It's definitely more prevalent in, for instance, Turkey, the Middle East, China, so countries along the old Silk Road. That's because there's a genetic component involved. Anyways, if you see this pattern, consider it. Consider the possibility, because otherwise, maybe nobody will think about it. So cascade sign is, in my opinion, a useful sign. I've only made a few diagnoses of neuro-Behçet in my career, but I think about 2 of those, and it's only like 3 times or so I suggested it, I actually used the cascade sign to suggest the diagnosis. So I find it useful. Another sign that's useful is the following. Here we see a patient who had subacute cerebellar signs and cranial nerve palsies, and we see areas of edema involving both middle cerebellar peduncles. Okay, and now let's look at the T1 weighted image with gadolinium, and we see a lot of small enhancing dots. So it looks a bit as if someone peppered the brainstem and the cerebellum, and especially the middle cerebellar peduncles. And this pattern, so the peppered pons and the peppered cerebellum, should make you think Klippers, which is a chronic inflammatory disorder characterized by lymphocytic infiltration and inflammation, typically also with enhancement perivascular, so the dot-like perivascular enhancement at the brainstem, the pons, that, as you know, responds extremely well to steroids. So this is the image before steroids. This is a couple of days after the initiation of a treatment with steroids. So, okay, Klippers, also a rare disorder, but with a very characteristic imaging pattern. And those, I believe, are the most grateful entities where we can use neuroradiological signs and ONT minis. This is a patient with a longitudinal extensive myelitis. We can see on the sagittal T2 weighted image an area of edema involving the entire cervical spinal cord. Transverse myelitis is basically a descriptive diagnosis. It means we have a myelitis involving a long part of the spinal cord, and it can have a lot of causes, but one of those has a sign associated with it. And if we look on the axial images, we can see the gray matter, which basically stands a bit out as even more hyperintense than the white matter of the spinal cord, and it looks a bit like the letter H. And if you see this, the H sign, that's very suggestive for MOGAD. MOGAD, as you know, is an antibody-mediated autoimmune inflammatory disorder of the white matter. These patients have antibodies against MOG, which is myelin oligodendrocyte, or well, let me think, myelin. Okay, I can't really remember it. It's myelin oligodendrocytic glycoprotein, I believe. Yeah, I think I'm correct. They have antibodies against that. It's a protein located in the myelin sheath, and it leads to demyelination. This all makes sense. And if you have it in the spinal cord, if you see the H sign, it's more prevalent. It's not pathognomonic. It's never, these signs are rarely 100% pathognomonic. You can also see it in NMOSD, for instance, but it's a lot more prevalent or more strongly associated with MOGAD. So if you see it, think MOGAD. And this brings us to infectious disorder of the central nervous system. Also here, we're going to discuss several imaging signs. And here are 3 signs that prove you have a parasite in the brain. We have the cyst with dot sign, we have the eccentric target sign, and we have the concentric target sign. Let's examine these signs in a bit more detail, and let's start with the cyst with dot sign. This finding is almost pathognomonic, if not pathognomonic, for neurocysticercosis. It is a parasitic disorder in which you have cysts which contain the neurocysticercosis larva. And that's the dot. That's basically the larva or the head of the larva inside the cyst, and the cyst is meant to protect the larva in the brain. So here is the parasite. Once again, we see the dot. That's the parasite. That's the larval head. And we see the protective cyst surrounding it. And here's another example, and yet another example. So the dot, as said, is the larval head, or the entire larva, I'm not really sure. And you can see this dot. Well, it doesn't really matter what sequence you're looking at, just look for a dot, either on T2 weighted images, on FLAIR images, susceptibility weighted images, or your T1 weighted images with gadolinium. And if you have a strong suspicion of neurocysticercosis, but you can't really see the dot, or you're not sure, do high resolution T2 weighted images like a KISS rather, or a 3D Fiesta. And here we see a small cyst with a small dot, but that was for us enough to strongly suggest or favor the diagnosis neurocysticercosis. So do high resolution 3D T2 weighted sequences when in doubt. This brings us to the next parasite. Over here we see a lesion on T2 weighted images, while patient has multiple lesions, but we're going to focus on the one in the right frontal lobe. And we see that it is composed of alternating hyperintense and hypointense rings. This is called the concentric target sign, and it kind of makes sense. We have concentric. It looks a bit like a concentric target. But the same patient has a different pattern on T1 weighted images with gadolinium. This is the same lesion. We would expect to see enhancement of alternating rings. We don't see that. We just see enhancement of the outermost ring. And then we have like an enhancing eccentric dot. This is the eccentric target sign. And these both signs combined are very suggestive for cerebral toxoplasmosis. How do you get those, or how do you explain those signs? And the cyst with dot sign, it was basically a protective cyst surrounding a larva. Is that the case here? Not really. It's also a parasitic infection, but it's not as if we're now here looking at the larva. This is not how this works here. This is an area of inflammation caused by a parasitic infection. We can call it toxoplasmosis abscess, although it is not a true abscess because it doesn't contain pus. We see a small enhancing wall surrounding the area of inflammation, and we see like the eccentric target, which is very often identified in toxoplasmosis lesions that are located superficially near the cortex or along the cortex. And how do you get that sign? Well, pathologically, there have been pathological studies. This is the area of toxoplasmosis infection and inflammation, and the eccentric dot is basically these lesions tend to arise along the cortex. They can surround a sulcus, and the eccentric target sign is basically a leash of inflamed vessels extending down the sulcus and entering the lesion. So that's the explanation for the eccentric target sign, and it's actually very specific in my experience for toxoplasmosis. But keep in mind that toxoplasmosis is an infection that is rarely encountered in immunocompetent patients, so it's typically seen in immunodepressed patients and then HIV patients. So if you see that sign in an HIV patient, I immediately say, oh, this is going to be toxoplasmosis, especially if the patient also has the concentric target sign, which is a sign described on T2 weighted images and consisting of these alternating T2 hyper and hypointense rings. And this is because pathologically these lesions consist of areas of hemorrhage surrounded by liquefaction and necrosis, and then another area of hemorrhage, and so on. And the end result is the concentric target sign. So alternating areas of hemorrhage and necrosis or edema. So all in all, if you have a patient with HIV, a concentric target sign, and an eccentric target sign, all in the same patient, think cerebral toxoplasmosis. The next sign involves shrimps in space. What does this entail? This is a patient with large lesions in the brain, and with one very large lesion located in the left cerebral hemisphere. There is a little mass effect despite the large size of the lesion, which should make you think this is something that actually destroys brain parenchyma, because if it was something that was, let's say, if it was pure edema or a tumor, it would cause mass effect, okay? So it doesn't do that. And if you look surrounding the lesion, you see a lot of very small dots, and they look a bit like stars. They look like a Milky Way. If you see that, Well, that's a sign of progressive multifocal leukoencephalopathy, which is an opportunistic viral infection that is typically seen in immunocompromised patients, typically HIV patients. Let's magnify these images a bit. We see here the area of demyelination, and we see the many little stars surrounding the area of demyelination. And the total image looks a bit like the Milky Way, which is why we call it the Milky Way sign. I also find this a useful sign, the small dots. Basically, we have the large area of demyelination, and the small dots correspond to the infection spreading through perivascular spaces to other parts of the brain or to the white matter surrounding the main area of demyelination. This is on FLAIR images, this is on T2 weighted images. And the shrimp sign, this is also a sign described in patients with progressive multifocal leukoencephalopathy. So for one reason or another, the middle cerebellar peduncles are a preferred location for PML. And when you have PML over there, the edema can extend along the dentate nucleus. The dentate nucleus is gray matter, so it is not really involved all that much. And then the edema surrounding the dentate nucleus can look a bit like a shrimp. Personally, I think this belongs to the one guy once saw it in one case and decided to make it into a sign because I don't know. I don't really find it all that useful, but maybe that's just me or that's personal preference. I also don't know how pathognomonic this is. I think the Milky Way sign is probably a lot more specific for PML than the shrimp sign, but I'm not sure. Okay, and that concludes signs in infectious and inflammatory disorders. On to the next topic, toxic metabolic disorders of the central nervous system. And in this part, we're going to encounter a lot of signs inspired by animals. So we're now entering a true neuroradiological zoo, so to speak. So the signs I'm going to talk about and the old minis are the following. I'm not going to read them out loud. Let's just jump right into it. Total of about 13 signs, as you can see. And the first one, I think we all know because it's basically in any radiology, neuroradiology textbook. So finally getting there. This is a patient with diffuse brain edema, but if we look at the brainstem looks quite white. This is the white cerebellum sign, or also called the bright cerebellum sign. The cerebellum is spared, as you can see. This pattern of diffuse brain edema is frequently seen in patients with severe hypoxic ischemic encephalopathy, so patients who suffered, let's say, cardiac arrest or who suffered strangulation, prolonged hypoxia due to aspiration, due to drowning, whatever. So the brain becomes completely infarcted, but especially in children, and the younger the children, the more likely the cerebellum can be spared, and this gives rise to the white cerebellum or the bright cerebellum sign, or sometimes also called the reversal sign. Now, I think nowadays this sign is not that important anymore. I think there's the quality of CT scanners is so good that we can recognize a diffuse brain edema. But I think in older times when image quality was a bit different, when there was no option to generate reconstruction of the coronal or the sagittal plane, the distinction between the bright cerebellum on the axial plane and the surrounding hypodense supratentorial brain parenchyma could probably be useful to suggest the diagnosis of diffuse brain edema. Now, in the sagittal plane, we can also clearly recognize it. I think the sign is a bit less relevant nowadays for the diagnosis, but nevertheless, it's well known and is also quite often seen because this entity, unfortunately, is not that infrequent for neuroradiologists. So sometimes it's also called the reversal sign because the supratentorial brain looks hypodense and the infratentorial brain, the cerebellum, looks hyperdense. Now, the next one is, has two names, I believe. We have the tiger stripe sign. This is a patient with an inborn error of metabolism leading to leukoencephalopathy or a leukodystrophy. We see abnormal white matter. It's symmetrically abnormal in both cerebral hemispheres. And if you see all these small hypointense stripes, this pattern, the tiger stripe white matter pattern, is typically associated with a genetic disorder called metachromatic leukodystrophy. It's an a genetic disorder caused by mutations in the gene for aryl sulfatase A. This leads to an accumulation of certain metabolites called sulfatides, which cause damage to the white matter. This is the most prevalent, or one of the most prevalent, congenital inborn errors of metabolism, which can lead to leukodystrophies. So it is, I believe, a pattern you should know. It's not 100% pathognomonic. You can also see it in some other also rare diseases like Krabbe disease, but remember this association because I think it is the most important one. So tiger stripe white matter, think metachromatic leukodystrophy, and the stripes you see or the dots you see basically reflect regions of perivenular white matter that is relatively preserved or preserved. Now, you can also say, well, it kind of depends on the way you interpret it. You can recognize stripes in it, or you can recognize spots in it. If it looks more like spots to you, you can call it the leopard skin sign instead of the tiger stripe sign. So whatever you call it, if you see this pattern, either tiger stripes or leopard skin, think metachromatic leukodystrophy. But remember, it's not 100% pathognomonic for this rare disorder, but at least it puts you already on your way in the category of the toxic metabolic genetic disorders. Here are some other examples of patients with a metachromatic leukodystrophy, and the patterns look slightly different in each patient, but in all of them you can recognize hypointense stripes or dots. So you can recognize tiger stripes or leopard skin if you want to. So you see this pattern, think metachromatic leukodystrophy. The next sign I'm going to talk about also has to do with tigers and is a so-called eye of the tiger sign. It has nothing to do with the classic 80s hit that featured prominently in the movie Rocky. No, it has to do with a genetic disorder which is associated with the accumulation of iron in the globus pallidus of the basal ganglia. This iron accumulation leads to necrosis. Necrosis is hyperintense on T2-weighted images, basically areas of liquefaction, and is surrounded by hypointense T2 hypointense iron. This gives rise to the so-called eye of the tiger sign on T2-weighted images, and it's associated with, as said, the genetic disorder pantothenate kinase deficiency, a disorder that was previously known under the name Hallervorden-Spatz disease, but that name is no longer used as Hallervorden and Spatz were Nazis who didn't really behave correctly during the Nazi times. So the name is no longer used, and the disease is now called pantothenate kinase deficiency. Now, because this is a disorder involving the basal ganglia, this can lead to movement disorders. It's a genetic disorder, so patients are generally younger. So if you see the eye of the tiger sign and the globus pallidus in a child with dystonia, think pantothenate kinase deficiency as your diagnosis, also an example where such a sign can lead to the diagnosis of a rare disorder. Now, this one goes under many names. We see an extensive area of signal abnormalities centrally within the brainstem in the pons. If we look carefully and use our imagination a bit, it looks a bit like a trident. Now imagine this is a patient who developed brainstem symptoms rather acutely after a rapid correction of hyponatremia. This is the trident sign of osmotic demyelination syndrome. Osmotic demyelination syndrome is, as the name implies, demyelination that occurs in certain areas of the brain that are more vulnerable to it, like the brainstem, after a rapid correction or a rapid change in osmolality in our blood, such as, but not exclusively seen in a rapid correction of hyponatremia. Now, this can look like a trident, but the area of dysmyelination in the brainstem has been likened to many things. For instance, it has also been called the monkey sign because you can see a monkey face in it if you use your imagination a bit, and the areas here that are preserved centrally correspond to the corticospinal tracts. And then we see the hyperintense changes surrounding it, looking a bit like a monkey sign, or if you want to, the eyes of an owl. So it's this, in this case, it's called the owl eye sign. Other patients or other authors have likened it to the snout of a nose. So it also goes under the name piglet sign. Still, other authors have compared it to a sombrero, so it's also known as the Mexican hat sign. And then you have the nerds, and there are plenty of nerds in radiology who recognize the Rebel Alliance sign in this entity. So yes, it goes under many names: monkey sign, owl eye sign, piglet sign, trident sign, rebel alliance sign, Mexican hat sign. So a lot of redundancy when it comes to describing the brainstem changes that can be seen in osmotic demyelination syndrome. And that's even more when it comes to osmotic demyelination syndrome. In a lot of cases, this shape or this morphology is not even present. So also keep that in mind. So when it's a bit shaped like this, yeah, you can use terms like trident shape or Mexican hat shape or whatever. In these specific situation, I don't even recognize the snout of a pig. In this case, I would, or the owl eye or whatever sign. In all other cases, these were also cases of osmotic demyelination. You can't recognize these entities. So keep that in mind. So we have an osmotic demyelination lesion. In osmotic demyelination syndrome, we can sometimes recognize these signs, but sometimes they are not even present. Then we have another one, also well known, I believe, in radiology, but not frequently observed in radiological practice because it is associated with a rare disease. That is the face of the panda sign. And what is the face of the panda sign? It basically refers to the appearance of the midbrain in a specific disease called Wilson's disease. Now, Wilson disease is also a genetic disorder. It's a disorder of our copper metabolism and can lead to copper deposition and toxicity in various parts of the body, can involve the liver, will often involve the liver, but also the brain. So we can have also neurological manifestations of Wilson's disease. And in the brain, one of the regions that can be involved, it typically involves the basal ganglia, but when it involves the midbrain, we get this so-called face of the giant panda sign. And why do we call it the face of the giant panda sign? In case you don't see it, here is a giant panda. And of course, the red nucleus that is preserved corresponds to the eyes. The substantia nigra corresponds to the ears. And then we have the area of edema centrally in the midbrain, corresponding to the cute rest of the face of the giant panda. So Wilson's disease is a disorder that is, well, pretty rare, I think. We don't often see neurological manifestations of Wilson's disease on imaging, at least I don't. So it's useful to suggest a diagnosis, especially a patient in whom the diagnosis is not yet known, but it's also not pathognomonic. So like, for instance, this is a patient with Wilson's disease. This patient also had a face of the giant panda in his midbrain, but this was a case of autoimmune encephalitis, more specifically anti-MA2 encephalitis. You can forget the name as far as I'm concerned. I just want to illustrate that this sign, although it can be helpful to suggest a rare disease, can also be seen in other rare diseases. So be skeptical. This is another typical example. And this is, I believe, more pathognomonic. This was a patient with sensory disturbances and sensory ataxia. The patient is known to abuse nitric oxide, so I don't really know how that is called in English. So the kind of gas that makes you laugh a lot used to be used as an anesthetic. We call it lachgas in Dutch, but I don't know how it's called in English. Anyway, patient abused this, then developed sensory disturbances, and on sagittal T2 weighted images of the cervical spinal cord, we see an area of myelitis located posteriorly, and on actual images, we see that this area looks like an inverted V. It involves the dorsal columns of the cervical spinal cord, which explains why the patient has sensory disturbances, and it's called the inverted V sign. It's typically seen in subacute combined degeneration, and subacute combined degeneration is basically vitamin B12 associated toxicity involving or disturbances involving the dorsal columns and the cervical spinal cord. This is an alt mini. It's not a sign, but I'm showing it because I think we will all encounter these cases. We should all know them. If you see like these bilateral symmetrical chunky calcifications in the basal ganglia and the thalami, and or in the dentate nucleus, think FAR disease. So there are two kinds of FAR disease. We have a genetic kind, which is also called primary familial brain calcinosis, in which you get these chunky calcifications, typically in deep gray matter structures, but it can also be secondary to a variety of endocrinological entities like parathyroidism and hypoparathyroidism and whatever, pseudo hypoparathyroidism, pseudo, and so on and so on. So endocrinological disturbances of the calcium and or phosphate metabolism. Okay, so this brings me to the next topic, specifically degeneration. Let's continue with signs and aunt minis of degenerative diseases of the central nervous system. Here are the signs and aunt minis we're going to talk about, and let's start by looking at birds. This is a mid-sagittal T1 weighted image of the brainstem, and if we use our imagination, we can recognize a penguin or a hummingbird in this mid-sagittal view. What does this patient have? Well, there is atrophy of the midbrain, and this atrophic midbrain now looks like the head of either a penguin or a hummingbird seated on a more bulky pons, which is the body of the hummingbird or the penguin. This is a sign classically described, and all neuroradiologists know it, in progressive supranuclear palsy. It's also, in my opinion, one of the most overrated signs in neuroradiology and often incorrectly used because, to be honest, this could also look a bit like a penguin if you use your imagination, or if you just look at the morphology of the midbrain and the pons, despite the fact that in this case, no macroscopic midbrain atrophy is present. If you look at images in the same patient 2 years later, even there we could say it looks a bit like a hummingbird or a penguin if you want it to be, but also here there is no clear midbrain atrophy, maybe a little bit, but you would easily miss it if nobody asked you to look at the midbrain. Now, another year later, now the midbrain has clearly become too small, has clearly atrophic, and is also the case on the follow-up MRI 1 year later. So if you look at the initial images of 2016 and the final images of 2020, you clearly see a difference. And it's only in those last two images that you could use or call this a hummingbird sign or a penguin sign. But admittedly, it's difficult. So in my experience, the day a radiology resident in training learns about a hummingbird sign is also the day he starts seeing them and reporting them. So you really have to tone it down a bit, their enthusiasm, and say, well, you can always recognize it. So when is it truly a penguin sign or a hummingbird sign? you have to have this. So the head of the midbrain has to be concave. It shouldn't be convex. If you look here it's flat. That's still okay. Here it maybe starts to become a bit convex, but isn't quite yet. Here it's clearly convex. So that's where I would start calling it. And that's not enough. Basically, you have to have atrophy of the midbrain, and it's better to evaluate that a bit more quantitatively. And yeah, we've seen this. So the hummingbird or the penguin sign, it is characteristic but not pathognomonic for a progressive supranuclear palsy. It can be almost pathognomonic if the atrophy is very advanced, but then it's better to use quantitative measures. For instance, what is something I do? Let's look at these images once again. Let's use the midbrain to pons ratio. And in a normal situation, your midbrain fits about 4 times in the pons. So a normal ratio is about 0.25. So you could actually measure that on midbrain sagittal images, or you could just, eyeball it and try to figure out how many times would it fit in there. And when does midbrain atrophy become very specific for progressive supranuclear palsy? If your midbrain fits about 8 times in your pons, if you can eyeball that, or if you measure it and your ratio is smaller than 0.125, then it becomes specific. Now there's a large area in between that is a gray zone, because the midbrain can also become atrophic, due to some age-related atrophy. It can also become atrophic and some other disorders, but not as severe as MPSP. So there's a gray zone. And that's also why, like, the hummingbird sign or the penguin sign is not really pathognomonic or not so specific, and it's very subjective. So actually, I don't really use it. I always measure it. I always measure the ratio of the midbrain to the pons, and I kind of rely on that. Another sign described in progressive supranuclear palsy is the appearance of the midbrain on axial images. And it is said that due to atrophy, the cerebral peduncles stand out, and now your midbrain looks a bit like Mickey Mouse. So we can see the resemblance, but to be honest with you, every midbrain you look at in the actual plane, you can recognize a Mickey Mouse head, in that configuration. So don't use it. It's overrated. It's so subjective that it is completely useless. Another sign often described in the literature is the morning glory sign. Also, that sign I find very difficult to use, so difficult that I decided not to even discuss it. Another sign that is more easy to recognize, and I believe a bit more useful, is a so-called hot cross bun sign. It is an atrophy of the pons in which we see a cross, and it looks a bit, your atrophic pons with that cross in between looks a bit like a hot cross bun, as we can see here. Looks tasty, but unfortunately this is a sign of a severe degenerative disorder leading to Parkinsonian symptoms and sometimes also cerebellar and autonomic symptoms. This is the same patient. This is the initial MRI. The pons is not atrophic yet, but we can see signal changes in the middle cerebellar peduncles. These already reflect degeneration of the pontocerebellar fibers, the fibers connecting the brainstem to the cerebellum. And in the same patient, a couple of years later, the pons has become completely atrophic, and we can clearly see a hot cross bun sign over here. And these are degenerated pontocerebellar fibers in the center of the brainstem. This is the same patient, but on sagittal images. So the patient initially presented already with some symptoms like gait ataxia, unsteady and clumsy walking. And on follow-up MRI, we see clear atrophy of the pons, but also of the cerebellum. So the hot cross bun sign is a sign of multiple system atrophy disorder in which there are some subtypes, and this is the cerebellar subtype. It is, however, not 100% pathognomonic, because this feature can also be seen in some other quite rare degenerative diseases, like, for instance, hereditary the genetic ataxias, some of the spinocerebellar ataxias. Now, multiple system atrophy tends to occur in older patients. If you see this sign in younger patients, also with signs of cerebellar ataxia, think one of the spinocerebellar ataxia syndromes, more specifically type 2, 3, 7, or 8. This is also this is a very subtle sign described in a rare disorder. This is the ear of the link sign. So we see these areas of signal increase on this FLAIR image next to the frontal horns of the lateral ventricles. These look a bit like these fluffy whiskers or hairs on the ears of this magnificent lynx. And this is a sign that can be seen in hereditary spastic paraplegia. It's a subtle finding. Also, we frequently see caps along the frontal horns of the lateral ventricles, so you should also be careful not to confuse your physiological caps with this sign. It can be a subtle imaging hint of this rare disorder in patients with spastic paraplegia. So if you have a clinical context, so a younger patient with spastic paraplegia, you see this finding, you can consider it a subtle imaging hint, but rarely will this be a pure radiological diagnosis, so rare disorder. This is a sign that is probably better known. We see diffusion restriction in the basal ganglia, but also in the thalamus. And in the thalamus, the area of diffusion restriction looks a bit like a hockey stick. This is called the hockey stick sign. And the same sign can sometimes be limited to the dorsal part of the thalamus, which we call the pulvinar. And when it is limited to this area, we call it the pulvinar sign. When you see these abnormalities on diffusion-weighted images, think Creutzfeldt-Jakob disease. This patient will often also have diffusion restriction in the basal ganglia and or in the cerebral cortex. Creutzfeldt-Jakob disease is also a rare disease, and patients typically present with a rapidly progressive dementia. This is also a pulvinar sign, but this pulvinar sign is associated with another disease. This is also not a diffusion-weighted sequence as you see, but a T1-weighted sequence. And we see areas of signal increase laterally and now dorsally in the thalamus on both sides. This is also the pulvinar. And this pulvinar sign on T1 is described in a genetic disorder, Fabry disease. Fabry disease is a multi-system genetic disorder, will involve multiple organs, can also involve the kidneys, for instance. And this is also an example of how signs, their importance can vary with time. In 2003, this pulvinar sign was increased or described as a pathognomonic imaging sign of Fabry disease. About 15 years later, an article was published in the same journal, the AGNR, redefining the pulvinar sign, and the conclusion is this is as a selective sign. This is actually a rare neuroradiological sign of Fabry disease. So it's more a sign that has some historical merits, but is actually not that useful for the diagnosis of Fabry disease. It's also not pathognomonic. Okay, we're almost through with this presentation. Let's talk about congenital disorders. And congratulations, you've reached the final part of this presentation, congenital disorders, neuroradiological signs, and aunt minis. So these are the signs and aunt minis I'm going to talk about in this presentation, and they will involve molar tooths, pancakes, race cars, and various animals, including, as you can see, dragonflies. Let's start with this, however. This is a patient with a genetic disorder called lysencephaly. And on this actual T1 weighted image, we see, first of all, that the brain looks extremely smooth. We see hardly any sulci or gyri in this brain. And if we look at the configuration, we can recognize a figure of 8 or an hourglass. which is why this morphology is called the figure of 8 sign or the hourglass sign. So this is a rare disorder. It's also a genetic disorder, and it's basically caused by a failure of migration of the developing neurons from the periventricular zone to their final region in the cerebral cortex. And this thick band is just a layer of arrested migrating neurons. So we see this very thick cortex. This is abnormally thick because the neurons have not reached their final position. Because there is no organization of the cortex, there are no sulci, there are no gyri, and at best we have some rudimentary development of the Sylvian fissure leading to a figure of 8 or hourglass sign. This is another sign that I believe is something we all know or should know as radiologists. Something in this patient is missing. I think everybody immediately recognizes, even if you don't know this entity, something is abnormal. The ventricular morphology looks abnormal, both on this axial T1 weighted image and on this coronal T2 weighted image. What is the reason for that? Well, something is missing, something is absent. And if you look at the sagittal T1 weighted images, it is immediately clear what is missing, namely the corpus callosum, the thick white matter bundle connecting both cerebral hemispheres. Completely absent in this patient. This is called callosal agenesis, and the absence of this white matter bundle leads to an abnormal configuration of the ventricles, both in the axial plane and the coronal plane. In the axial plane, we get what is called the racing car sign. And here you have two racing cars. Basically, the third ventricle located over here is the actual car. And then we have the frontal horns and the trigonum and the posterior horns of the lateral ventricles, which correspond to the wheels. So if you look at that, you can kind of recognize a racing car in there, I believe. And then we have the morphology of the third ventricle and lateral ventricles in the coronal plane. And this one goes under many names. Let's go over them all. Well, first of all, what is missing normally? This here, we see here these two white matter bundles. These should be connected to one another, and then it's the corpus callosum. But because there is no corpus callosum, white matter has developed into two thick bundles running medially of the lateral ventricles, causing this bizarre morphology, and these are called the Probst bundles. So these are basically the axons that want to cross the midline, but they can't, so then they just run medially of the lateral ventricles. And this gives rise to various signs. We can liken the appearance of the third ventricle and then here the lateral ventricles to either a moose head. There is clearly a moose head appearance. We can liken it to a steer horn or steer horns, the steer horn appearance. Now, for some reason, just comparing it to a steer horn isn't sufficient for some people, probably Texans, who rather see a Texas longhorn in this coronal view. Then we have the buffalo head appearance, and we even have a Viking helmet appearance, despite the fact that historically speaking, Viking helmets didn't have horns. It was Richard Wagner who introduced these kind of helms in his operas, and as a consequence, we're stuck with this idea that the ancient Germans or the Vikings wore helmets shaped like this, but they didn't. So Viking helmet appearance, in my opinion, is historically a completely incorrect term. Let's move on to another disorder, also a rare disorder, but once again a disorder with a very typical appearance on imaging studies. Let's look at the midbrain in this patient. We've examined the midbrain in patients with progressive supranuclear palsy. This patient has something completely else. We see that the patient has quite thick and quite horizontally orientated superior cerebellar peduncles. This makes the midbrain look a bit like a molar tooth, and we call this the molar tooth sign. The molar tooth sign is described in a rare genetic disorder called Joubert syndrome. Joubert syndrome is characterized by both the molar tooth appearance of the midbrain on axial images and dysplasia of the cerebellar verbis. So if you have the combination of both these findings, this is very suggestive for this rare autosomal recessive disorder called Joubert syndrome, in which patients typically present shortly at an early age, often shortly after birth already, with hypotonia, ataxia, oculomotor apraxia, rapid shallow breathing, and other symptoms. So this is Joubert syndrome. It's a ciliopathy. And then we have another disorder, also a genetic disorder, can be caused by various kinds of mutations. We see the child on the left, we see a child on the right. The child on the right is a normal child, and the child on the left, we see atrophy of both the pons and the cerebellum if we compare it to the normal child. So when discussing pediatric cases, I often like to compare it with normal children to better see the pathology. This is the imaging hallmark of a genetic disorder, or basically a group of genetic disorders called pontocerebellar hypoplasia. These are often severe. These children, the diagnosis, it is often quite clear at birth or after birth that these children have something going on, and they often do not grow old, unfortunately. And the coronal plane, the appearance of the hypoplastic cerebellum in combination with the vermis that can look a bit more preserved is sometimes likened to a dragonfly sign or a dragonfly. So here we have the vermis, and here we have the very flat dysplastic cerebellar hemispheres, and the end result is a so-called dragonfly. The next sign I would like to discuss with you is a so-called transmental sign. This is a sign described in focal cortical dysplasia. Focal cortical dysplasia is a cortical malformation. It involves the cerebral cortex and often leads to epilepsy. And because the cortex typically originates, or because neurons are typically formed near the ventricles, these abnormal neurons have to migrate to this region where they then organize abnormally. And we often see a line of scar tissue indicating the migration path of this abnormal cortex. This is called the transmental sign. This is also an important sign. First of all, it can help you detect a focal cortical dysplasia because these cortical malformations can be very subtle. Here it is a bit less subtle. We see clear thickening of the cortex in the depth of a sulcus, but nevertheless, it's not really in your face, is it? So if you then see the transmental sign going from the ventricle to the cortex, this is really, really helpful. And also because in some cases there is a lot of confusion. Could this be like a tumor or is it a malformation? Now the implications can be huge in terms of therapy and follow-up, but if you see a transmental sign, this is more suggestive for a cortical malformation, for a focal cortical dysplasia. And a similar sign has been described in a genetic disorder called tuberous sclerosis. Tuberous sclerosis is one of the phacomatoses. Those are genetic disorders that lead both to skin abnormalities and neurological abnormalities. And these patients in their brain often have so-called tubers involving the cortex and the subcortical region. So we see these abnormalities immediately underneath the cortex, and then we have a thin line going to the ventricle. This is called a radial band sign, and it's probably a bit similar to the line of scar tissue and focal cortical dysplasia. This patient has multiple of these radial band signs, as you can see. So that makes focal cortical dysplasia less likely because that's not often multifocal. And the patient has other hallmarks of tuberous sclerosis, like here a so-called subependymal nodule, which is also typically seen in patients with tuberous sclerosis. This brings us to another very classic appearance of a rare entity. This is a patient with craniosynostosis. So this is a baby in whom the sutures have prematurely closed, leading to the development of an abnormal skull morphology. And in this case, the skull looks like a clover leaf, which is why we call this the clover leaf skull. And practically almost all sutures have fused in this child. This is a pancake brain, and this is, I believe, the final sign of this presentation. Also infrequently seen, it is associated with a rare fusion abnormality, or rather cleavage abnormality of the brain called holoprosencephaly. Holoprosencephaly can have various degrees of severity. This is the most severe kind, called a-lobar holoprosencephaly. And what happens in these patients? Well, basically, we start with the telencephalon originates embryologically as one vesicle that has to split in two vesicles. And when it does that, it's called the telencephalon. If it doesn't happen, you get holoprosencephaly. So this patient has an unfused telencephalon and diencephalon. We see a large monoventricle, which communicates with the CSF space over here. And you can ask yourself, why do they call it a pancake brain? I don't really see it. Well, maybe it's better seen in these very extreme cases that were diagnosed prenatally. This is a fetal MRI, and it's also called a pancake brain sign because we basically just see a very thin rim of residual brain, or brain rather, lining the skull. It's as thin as a pancake, which is why it's called pancake brain sign. Okay, that concludes my presentation on imaging science and ontminis and neuroradiology. We've seen a lot of them. Let's summarize, or let's try to distill some key points out of this presentation. Well, I think it should be clear that radiological science can be very helpful to recognize certain pathological entities. They can also help us recognize certain structures in the brain. However, we should also not overrate their usefulness and their pathognomonic character. Keep in mind that radiological science and ontminis belong to the so-called first system of visual analysis and cognitive thinking. It's fast, but it's prone to errors. So a bit overrated, so be skeptical or be critical. Some, however, can be, in my opinion, very reliable for a specific diagnosis. If I see lateral ventricle shaped like this, I know I'm going to see some kind of dysgenesis of the corpus callosum on the sagittal image. If I see this image on a T1 weighted image with gadolinium, I know there's going to be a developmental venous anomaly just because, well, it just looks like that. We see like the caput medusae sign and a lot of snakes on the head of Medusa. So then there are some signs that maybe they aren't 100% pathognomonic. They can nevertheless be very helpful for finding the right diagnosis, because these signs are associated with very rare diseases that you wouldn't automatically think about, like for instance the panda sign in Wilson disease, the onion bulb sign in Ballo's concentric sclerosis, the cascade sign in Behçet disease, and the eye of the tiger sign in pantothenate kinase deficiency. And then we have some signs that, in my opinion, are unreliable and sometimes even confusing and often incorrectly used, like the Mickey Mouse sign for progressive supranuclear palsy, even the hummingbird sign for supranuclear palsy. And we have the swallowtail sign. I didn't even discuss it because I believe it is so difficult and so subjective that I don't find it all that reliable and useful. Also, something to keep in mind is that there is a lot of redundancy in the world of science. It's tempting if you are confronted with a case, and if you look at it from a certain angle, you can recognize maybe a pig snout or a monkey or all eyes in it, to say, let's publish this as a new radiological sign. Oh yeah, okay, then we end up with like 6 signs for the same entity. How useful is that? It becomes a bit confusing in my experience. It's okay, it's also gives rise to like fun presentations. You can make fun presentations of them, but I sometimes question the utility. Same is true for callosal agenesis, moose head, steer horn, Texas longhorn, even Viking helmet, all to describe the same imaging appearance. And then we have a problem of lexical ambiguity, that sometimes we have like the same sign that can be used for 2 different entities. For instance, we have 2 string of pearl signs in radiology, one to describe fibromuscular dysplasia and one to describe internal watershed infarctions. Or we have 2 owl-eye signs, one to describe central pontine myelinolysis, but, and I didn't added in the cases because it's more spinal, and I try to limit the number of spinal cases, but it's also a sign described to describe spinal infarction involving the anterior horns of the gray matter, and can also be seen in certain infectious disease of the spinal cord like polio or polio-like disorders. So, okay, let's say that these signs can be helpful, but we should use them we should be a little bit critical when we use them. Also keep in mind that nothing is 100% certain, not in medicine, not in radiology. Medicine, as William Osler famously said, is a science of uncertainty and an art of probability. Now, this is a very interesting article. I borrowed a bit from it. The authors here only discuss about 10 signs, but they gave, in my opinion, a very critical and also a quite fun to read, made a fun to read article about the utility and the use of descriptive neuroradiology science. And there's even a complete book. I have a copy of it. I find it a very fun book because, as said, you can be critical about the use of science, but they're a good way sometimes to teach things. Yeah. So I hope you found this presentation useful. If you have any questions, comments, or feedback, you know how to reach me. You can send me an email, theradiology.online@gmail.com. I'm way behind in replying, I have to admit, however, but I do try to do that. So every now and then I make some time to reply to my emails, or you can just leave a comment in the comment section. I hope you found it interesting. It's way too long. I didn't even discuss all the science out there. I even made a selection, but I'm very bad at, kill your darlings, like William Faulkner said. I'm very bad at that. So I always make these presentations way too long. So thank you very much for watching.